Today, we are talking about health economics in clinical trials and what that means in practice. It's about showing not just whether an intervention works, but whether it's worth it, linking outcomes, costs, and real-world value to guide what truly makes sense to implement in healthcare.
It's wild to think that research can take nearly 17 years on average to reach clinical practice, and some of it never even does. A lot of that happens because we focus so much on proving something works without looking at whether it's worth the investment. Integrating health economics helps connect those dots, showing both impact and value so good ideas actually make it into practice.
At its core, an economic analysis or economic evaluation is a structured way to compare the costs and outcomes of different healthcare options, so we can see not just what works, but what delivers the best value. On one side, we have the full range of costs, including medical expenses, staff time, equipment, and the resources needed to deliver an intervention. On the other side, we look at the consequences and outcomes it produces. These are things like clinical improvements, quality of life gains, and overall patient well-being. Bringing these pieces together helps us understand not just what an intervention does, but the value it provides relative to what it takes to implement. And when this thinking is built directly into a trial's design from the start, it fits naturally with the clinical workflow. It produces evidence that's meaningful both clinically and economically in real-world settings.
When we think about why economic evaluation matters, it really comes down to a few realities. First, we already have many interventions that work clinically. That part isn't the problem. The challenge is that our budgets are limited, so we can't fund everything at once. That means we're constantly forced to make strategic choices about which options to prioritize. Economic evaluation helps us answer the key question: which interventions give the best health return for the money we spend? And ultimately, that's how we maximize population health within the resources we actually have.
An economic evaluation follows a very structured path. We start by identifying the relevant costs and outcomes that need to be compared. Then, we measure them: how many resources are used, what health effects are produced, and how they differ between options. After that, we assign value to those pieces, whether that's monetary costs or utility-based outcomes. And finally, we compare the options to understand their incremental cost effectiveness. Step by step, this framework moves us from describing the inputs and outcomes to determining which intervention truly offers better value for the resources invested.
This table breaks down common methods of economic evaluation, and you can really see how each one focuses on different ways of defining value.
All economic evaluation methods use cost data for both the new treatment and its comparator, but they differ in how they measure outcomes. Cost minimization is used when outcomes are equivalent, so the focus is solely on cost. Cost effectiveness measures outcomes in natural units, like life years gained or symptom reduction. Cost utility goes a step further by using QALYs or allocate to capture both quality and length of life in a single metric. And cost benefit expresses everything in monetary terms, which makes comparisons across sectors possible. The choice among these methods depends entirely on the research question and how outcomes need to be valued to understand whether an intervention offers good value for money.
Economic evaluations can be applied in a wide range of decisions across the healthcare system. They can help compare different clinical strategies, like choosing between group therapy and medication protocols. They can assess program scale by evaluating whether individual or group-based delivery models offer better value. Timing is another area. Understanding whether early screening or treatment-only approaches produce better outcomes for the resources used. We can also compare different healthcare settings, such as inpatient care versus day surgery centers, to see which delivers greater efficiency. Staffing models are another key application, examining how different workforce compositions, like nurse-led versus physician-led care, affect both costs and outcomes. We can also use economic evaluations to support comparisons across conditions, helping determine which interventions provide the best value across different clinical areas and disease management programs.
When planning an economic evaluation, it starts with the basics: defining the research question, identifying the intervention and comparators, and setting a realistic time horizon.
Right. And from there, it's about understanding resource use, deciding which outcomes matter, and building a practical data collection plan that balances feasibility, ethics, and affordability. Getting these fundamentals right sets the foundation for everything that follows.
Once the fundamentals are established, the focus shifts to how the evaluation will actually be structured and analyzed. That means defining the analytical perspective. In practice, economic evaluations usually adopt a societal, healthcare system, patient, or some other perspective. The selected analytic perspective emphasizes different cost bearers and financial burdens. It also means selecting the evaluation method that fits the research question and deciding whether the results can come directly from the trial data or if longer-term modeling is needed to capture broader impacts. These choices ultimately determine how meaningful and useful the economic evaluation will be for the relevant decision-maker.
In essence, economic evaluations really need to be part of a trial from the very beginning, not something added later. When it's built in early, right from the pre-funding stage, it shapes smarter design, better data collection, and more meaningful results.
Costing an intervention starts with identifying what differs from usual care in terms of delivering the intervention itself and its related impact on health-related outcomes. The perspective matters as well, whether we're looking from the viewpoint of society, the health system, or the patient, because each captures different costs and consequences. Paired with an appropriate time horizon, this approach gives a complete and accurate picture of the true cost of an intervention.
As Liam just mentioned, one of the first choices we make is the perspective, because that determines whose costs count. From a health system perspective, we are mostly interested in direct healthcare costs. That might include medications, outpatient visits, emergency department use, hospitalizations, diagnostics like lab tests and imaging, and community services such as home care, rehab, or mental health programs.
A societal perspective takes a broader view. It still includes all those direct health system costs, but it also brings in indirect and out-of-pocket costs that matter for patients and families. Things like informal caregiver time, productivity losses from missed work or reduced performance, and patient expenses such as travel, parking, or medications not covered by insurance. It can even capture educational impacts, like school absenteeism or the need for extra support. In the description section of this video, we've included a link to a table that shows how perspectives differ in who counts, which costs are in scope, and how broad the view is.
Once the perspective is clear, we can zoom in on costs that are specifically related to the intervention. These are the items that would realistically be needed if the intervention were rolled out in practice. That includes the intervention package itself, like medications, devices, materials, and other consumables. It also covers delivery costs, such as staff time, clinic space, technology platforms, and any transport or media outreach needed. On top of that, we account for training costs, including trainers and trainees' time, travel, and venues, as well as incentives that support adherence, such as small financial or non-financial rewards.
Just as important is what we deliberately leave out. We usually exclude pure research costs like investigator salaries, trial coordination infrastructure, and incentives paid only for completing research questionnaires, because those would not be part of routine implementation. For data sources, we can draw on patients, clinical staff, family members, health records, and administrative databases. Data collection might use case report forms, patient questionnaires, structured interviews, or extraction from routine data and diaries. The goal is to capture intervention-related costs in a way that is accurate, feasible, and consistent with how the intervention would operate in the real world.
So far, we have focused a lot on costs, but economic evaluation can also pair costs with outcomes. One big decision is how to measure those outcomes. Health utility measures like EQ5D, SF6D, or the Health Utilities Index give us QALY weights that let us calculate incremental cost per QALY gained and compare across very different diseases. Generic health-related quality of life instruments, such as the SF36 or GHQ12, provide broader profiles of functioning and well-being and can be used to estimate cost per unit change in a summary score or domain, although comparisons across conditions are harder.
Disease-specific quality of life tools are usually more sensitive to changes in the particular condition being studied, which can be helpful when effects are subtle, but their scores are not comparable across unrelated diseases. Finally, we have natural units, like cases detected, exacerbations prevented, or improvements in functional status. These outputs are very intuitive for healthcare providers, but do not support cross-condition comparisons. In practice, many pragmatic trials combine more than one type of outcome measure. For example, pairing a disease-specific measure with a utility instrument, so that both clinical relevance and broader comparability are captured.
To make this more concrete, the EQ5D5L is a commonly used example of a preference-based instrument. It asks patients to report their health across 5 dimensions, such as mobility, self-care, usual activities, pain or discomfort, and anxiety or depression, each with 5 levels of severity. That simple profile then gets converted into a single utility value using a country-specific scoring algorithm, placing each health state on a scale where 0 usually represents a state equivalent to death and 1 represents full health. We have also included a link that illustrates this conversion process visually. Just keep in mind that this example is for teaching purposes only and does not use the true Canadian EQ5D5L coefficients.
In a pragmatic trial, we can collect EQ5D5L at baseline and follow up, or at several time points, and then use those utility values to estimate QALYs by looking at the area under the curve over time. For example, in the curve here with 3 quality-adjusted life year measurements, we can estimate the area under the curve to be 0.8 QALYs.
Once we have the costs and QALYs side by side, we can summarize them using the incremental cost-effectiveness ratio, or ICER. The ICER is the additional cost of one intervention compared with another, divided by the additional health effect it produces. It is calculated as the difference in mean cost between the intervention and comparator, divided by the difference in mean effect, often QALYs. It is interpreted as the extra cost the respective payer would spend to gain 1 additional unit of effect with the new intervention instead of usual care. We then compare that ICER with relevant willingness to pay thresholds to decide whether the intervention represents good value, which we'll talk about shortly.
This table walks through a simple hypothetical example where we are testing a new medication on top of usual care compared with usual care alone. In the first column, we list the resources or outcome events captured in the trial. That includes background medications, the new medication, and 3 types of events we have captured in a trial. The second column shows the unit cost from a healthcare system perspective for each item over 12 months or per event. The third column shows the change in quality-adjusted life years for each item, which is a decrement in utility when that event occurs.
In the bottom rows, suppose we have already multiplied event rates by unit costs and by utility decrements, then summed across items. After doing the calculation, we estimate the mean cost and mean QALYs per patient in each arm, which are the key inputs for calculating the ICER.
Continuing with our example, where we estimated the mean annual cost per patient is $13,000 in the control arm and $15,500 in the intervention arm. We also estimated that the mean quality-adjusted life years were 0.76 in the control arm and 0.82 in the intervention arm, If we plug those values directly into the ICER equation, we get an incremental cost of $2,500 and an incremental QALY gain of 0.06. Dividing the incremental cost by the incremental QALYs gives us an ICER of $41,667 per QALY gained. So, from a health system perspective, that would be the additional cost the system pays for each extra quality-adjusted life year if it were to adopt the intervention.
An ICER on its own is just a number. To decide whether it is acceptable, we need a willingness to pay threshold. That is, the maximum amount a decision maker, like a health system or public payer, is prepared to pay for one additional QALY. Many systems talk about ranges such as $50,000 to $100,000 per QALY, although the exact value is a policy choice.
Interpreting our example, if the health system's willingness to pay is $50,000 per QALY, then an ICER of $41,667 falls below that threshold. So we would describe the intervention as cost-effective. If the ICER were above the threshold, the conclusion would flip.
The worked example uses mean costs and mean QALYs, which is standard, but it hides an important complication. Real-world cost data are often highly skewed. A small number of patients can generate very high costs, for example, due to prolonged intensive care or complex complications.
When costs behave like that, the usual normal theory confidence intervals around the ICER are not reliable. Best practice is to use a non-parametric bootstrap. That means repeatedly resampling patient-level data, or cluster-level data in a cluster trial, and recalculating incremental costs and QALYs each time. Those bootstrap replicates give us an empirical joint distribution of cost and effect differences that we can use to summarize uncertainty more robustly.
Once we have those bootstrap replicates, the next step is to make the uncertainty visible. One way is the cost-effectiveness plane you see here. Each point on the plot is a bootstrap draw showing a pair of values for incremental QALYs and incremental costs. The cloud of points tells us how often the intervention lands in each quadrant and how tightly results cluster around the point estimate.
From the same data, we can also build a cost-effectiveness acceptability curve, or CEAC, which summarizes the probability that the intervention is cost-effective at different willingness-to-pay thresholds. In more complex settings, net benefit regression can be used to adjust for covariates or clustering while staying in the same framework.
The CEAC on this slide shows the probability of cost-effectiveness on the vertical axis and willingness to pay per QALY on the horizontal axis. For each threshold, we look at how many bootstrap replicates have a positive net monetary benefit. That proportion is the probability that the intervention is cost-effective at that willingness to pay.
In this example, at a willingness to pay of 50,000 Canadian dollars per QALY, the curve is at about 0.88. That means in 88% of our bootstrap samples, the intervention delivers more value than the comparator at that threshold. So there is strong, but not absolute evidence that the intervention is cost-effective for the health system when decision makers use a 50,000 per QALY benchmark.
To wrap up, this module showed how health economics can be integrated into pragmatic trials to quantify value for money, not just clinical effectiveness. We started with perspectives and cost identification, moved through QALYs and ICERs, and finished with tools like cost-effectiveness planes and CEACs to communicate uncertainty. When you design or interpret pragmatic trials, think early about perspective, data sources, and how decision makers will use the ICER and CEAC in real policy questions. Thanks for joining us for this module. If you found it helpful, please subscribe to the channel and hit the bell icon so you get notified when new pragmatic trials content is posted.